This is Raj
and Niya with your favorite USMLE channel, where we help you gain in-depth understanding of the high-yield USMLE topics and score phenomenal on the steps.
We're teaching medical content for all steps using our own personally crafted mind maps and algorithm that's going to make concepts stick.
What you can expect in our videos is a lot of integration, as well as getting a clinical perspective of what's truly important to learn.
Hope you enjoy this video.
Please subscribe to our channel if you haven't already, and hit the bell button to receive notifications once we upload new videos.
Thank you for watching. Hey guys, I'd like to welcome you to a very important and a very interesting subject, which is going to be on cardiac action potential. Alright guys, so to begin, what I need to do is let's simplify this thing as much as possible. Number one, in order for your heart to contract, what do you need? You need a stimulus. You need an electrical current to be generated by the heart itself. That is the coolest part about the heart, because the heart is called a pacemaker. Alright, so firstly I need the heart to generate an impulse by itself, and then I need that electrical current to get transmitted along some wires which is present in the heart, and transmit that electrical energy into the muscle cells and cause the electricity to travel within the muscles and eventually cause contraction. Alright, so that's the story which I'm going to tell you today. So let's begin. So I want you to take a look at the heart right here. Alright, when you look at the heart right here, I want you to focus on the SA node, AV node, bundle of His, and then the Purkinje fibers. And as we all know that the SA node is the pacemaker of the heart, and I will tell you very shortly why that is so. But either way, for now I want to generate an electrical current starting from the SA node, and that's going to travel to the AV node and through the bundle of His and eventually the Purkinje fibers, and eventually transmit that electricity into the cardiac myocytes, and then the myocytes is going to bring about contraction. Alright, so now I want to talk about the action potential. In order to talk about the action potential, as you guys already know, you know that there is two types of action potential curves out there in your books. So one is the nodal fibers and the other is the action potential curve of the myocytes. So I like to begin with the myocytes first. Reason is, once you understand how the action potential curve of the myocytes work, it's so much easier to understand the nodal fibers. Alright, so let's begin. This is the curve that you guys need to understand. So if you look at this curve, you see that there is 5 phases in total. There's a phase 0, phase 1, 2, 3 and 4. Alright, the odd thing about the action potential curve of the myocytes is that it is going to need an electrical stimulation to come and give it a stimulation to kickstart the whole process. So where did the electrical stimulation come from? You guys already know it's going to come from the nodal fibers. So you're going to get an electrical stimulation right here. Alright, once the electrical stimulation comes and kicks in to the myocytes, what's going to happen is you need sodium entry into your cell. Alright, sodium entry. Now the sodium entry is an important topic of interest. These channels which I've drawn here, this is your sodium channels. Alright, your sodium channels, what you need to know is there's two types of gates. One is the M gate and the other is the H gate right here in red. So what happens is, the moment you give an electrical stimulation, the M gate immediately opens. Once it opens, the H gate starts to close. Little by little it starts to close, but the M gate snaps open and the H gate starts to close. So as you see here, there's a very short time within which your sodium actually enters into the cell. Alright, so it's a very short time within which sodium actually enters into the cell, and then by the end of it, the H gate comes and shuts it off, and then the M gate is actually open. So at this part, your sodium channels no longer allow sodium to enter into the cell. Alright, so during phase 0, that's what happened. You get a stimulation and your M gate opens and your H gate starts to close, during which time sodium enters into the cell and eventually H gate's gonna close. Is that the only thing that happens during phase 0? No, it's not. The sodium channel opens first, but the slight positivity that increases is going to open up another channel which is going to be known as the calcium L-type channel. Alright, now the calcium L-type channel opens up here, But at the same time, another channel also opens up, which is going to be called your potassium channel. So basic point I want to remember during phase 0 is you have 2 ions entering the cell and 1 ion leaving the cell. Which 2 enters the cell is sodium and calcium. What exits the cell is potassium. But the idea that you need to understand between this calcium and potassium relationship is how much of calcium goes into the cell initially versus how much of calcium goes into the cell later on, and the same goes to potassium. So if I had to draw the calcium entry into the cell, it would look something like this. Initially you're going to have a lot of calcium entering the cell, but as you go further and further in the curve, you're going to have less and less calcium entering the cell. Whereas if I drew potassium entry, actually potassium exiting the cell, what would it look like is the exact opposite. Initially less potassium leaves the cell, but as we go to the end, what's going to happen is more and more potassium leaves the cell. Alright, just for a quick understanding, I also want to remember this image right here. I'm going to draw a cell in which, when I show this cell, I want you to ask yourself a question. Which ion is primarily intracellular? It is potassium. Alright, what is extracellular? You have sodium and you have calcium. So I want you to remember this is a resting cardiac muscle cell. Alright, resting cardiac muscle cell, and I want you to go through this whole process and see what kind of change you're going to do to this cell. So as I told you in phase 0, you're entering sodium, you're entering calcium, and potassium is exiting the cell. So really think about this part. Now once you go during phase 0, we already know sodium, calcium enters, potassium exits. Alright, 2 goes in, 1 goes out. Alright, what happens at this peak is your H gate shuts off, right? Your H gate shuts off, which means your sodium channel will close by the point it goes up. That's what I told you. The sodium channel opens up really fast, short time within sodium goes in, and then sodium channel shuts off right here. So sodium channel shuts off right here, and then that's the reason you get the drop off. The drop off here is because the sodium channel now is closed. Okay, what happens during your phase 2? It's very simple. Calcium goes in, potassium goes out. So you get a beautiful plateau right here. All right, and what channel is it going through? The calcium is calcium L type channel. All right, calcium L type channel, and then somewhere along this part right here, your calcium L type channel is gonna close. This is a timed channel. There's like a time clock on it. After a certain amount of time it's open, it will shut off by itself. Important thing for you to remember, it closes somewhere around here. So what happens during phase 3 is pretty straightforward. You already know. It's just the exit of potassium. You see, a lot of potassium goes out, right? And eventually you're going to come to phase 4. All right, so I want you to take a look at this cell again. So what have we done? If you look at the cell, you basically put a lot of sodium into the cell, a lot of calcium into the cell, and you put a lot of potassium outside the cell. So what have you done? You've completely changed the normal homeostatic cell. You completely reversed the whole thing. So you can think about it now. Wait a second. Now you finished one action potential, right? You're coming to phase 4. Now in order for you to have another action potential, you need to flip this back to the resting state, right? You need to flip it back in the sense you need to put the sodium back outside, the calcium back outside, and take the potassium back in. So tell me 2 types of pumps you're going to need here. You're going to need your sodium potassium pump, and you're going to need your sodium calcium pump. Now the thing is, you're working against a lot of energy here. So what are you going to need? These pumps need to be ATPase pumps. You need energy in order to reverse whatever you've done. So what do you have during phase 4 is sodium potassium ATPase pump and sodium calcium ATPase pump, which completely reverts the cell resting membrane potential back to where it should be, so you can kickstart another action potential. Now we've learned about the action potential curve of the atrial and ventricular muscle fibers. It's time to track back to figure out exactly what triggered everything's motion. Alright, so what triggers an action potential of the atrial and ventricular muscle fibers is the nodal fibers. Now if I asked you what is the pacemaker of the heart, you're probably going to tell me SA node, but I would like to ask you, why is the SA node the pacemaker of the heart? Why is it not the AV node or the bundle of His or the Purkinje fibers? Why is SA node taking precedence over everybody else? And that's not just the question alone. I would also want you to dissect and tell me which phase of the action potential curve is the actual pacemaker of the heart. Alright, you'll know the answers to all of this after today's lecture. So let's begin. So I'm going to draw the nodal fibers curve action potential right here. And this is going to look a little different from the previous curve that you've learned. Alright, but it looks a little similar, so I'm going to label them for you. I'm going to call this phase 0, phase 3, and then phase 4. Alright, what's the first important thing that I want you to realize is the presence of an inclination on phase 0 and a declination on phase 3. Alright, so what happens during phase 0 is pretty much what happens during the phase 0 of the action potential curve of the atrial and ventricular muscle fibers. However, you see that it is not a peak but rather a very smooth curve. The reason is you do not have sodium entry into the nodal fiber cells during your phase 0. Alright, so what happens is you have calcium channel. It is the exact same calcium channel that you learnt about in the previous curve, and it is a calcium L type channel, and it looks exactly like this. The calcium goes in a lot at the beginning, but as you go into phase 3, there's less and less calcium going in. And same goes with the potassium channels. Potassium channel looks exactly the same as the previous curve as well. Initially there's less potassium leaving the cell. However, as you go closer to the phase 3, it's more and more potassium leaving the cell. Alright, so that's what happens. But again, what is the pacemaker of the heart? You still need a stimulation to trigger phase 0, but look at this phase 4. I want you to focus very closely on this phase 4. Phase 4 is the coolest part of the heart, guys. This is what you need to know. Alright, so previously, if you recall the sodium channels that was present, what caused that sodium channel to open? It was a positive charge, wasn't it? It was a depolarization that caused that sodium M gate to snap open, during which time the H gate was closing and you got your sodium entry. But do you have a sodium channel in this phase 4? Yes, there is. And this sodium channel in this phase 4 is right here. The initial part of the curve is a sodium channel. But you know what the funny thing about this sodium channel is? This sodium channel opens due to hyperpolarization, not depolarization, but a drop in charge. Hyperpolarization is going to cause this sodium channel to open. That's so funny that they call it sodium funny channel. Alright, so this is your sodium funny channel, and once this sodium funny channel opens and you get sodium entry into the cell, that's going to open another channel here, which is going to be called your calcium T-type channel, not L but calcium T-type channel, and then you're going to go back into your phase 0 and so on and so forth. So now if I asked you, what is the pacemaker of the heart? You're going to tell me it is the phase 4 of the nodal fibers. Very good. Now if I asked you which channel would make the heart have the property to have its pacemaker function, you're going to tell me it's the sodium funny channel. Alright, the sodium funny channel is gonna get open whenever you have hyperpolarization. That is by itself what's gonna make the heart have its pacemaker function. Alright, so it's the sodium funny channel that's the most important in order for the heart to beat by itself. Very good. Alright, now the question that I was asking you before was, why is it SA node that actually is the pacemaker and not AV node? So if you look at the curves, I'm going to put an SA node, AV node, bundle of His, and Purkinje fibers. If I had to draw the curves, they would look something like this. This is the SA node, then you have AV node, then you have bundle of His, and then you have Purkinje fibers. What I want you to focus on is the phase 4 of all of these different nodal fibers. Which one has the highest slope? There you go. SA node has the highest slope. It is much more steeper, so it generates its impulse really fast, and that's the reason SA node takes precedence. Once an impulse is generated, it's immediately conducted in the electrical fibers and then to the muscle fibers, and eventually brings about a contraction. Very good. So this is basically how the heart is able to generate its own electricity. You can answer a lot of questions in the USMLEs just by knowing this. Let me ask you a question. Niya probably mentioned something about a medication that we are using in heart failure with reduced ejection fraction, which is actually newly approved, something called ivabradine. Ivabradine, which is used in patients with heart failure with systolic dysfunction. And this medication actually is targeting your sodium funny channel. So there it is. Sodium funny channel is blocked. So if you gave somebody ivabradine, you wouldn't open your sodium funny current. So what would happen is you would decrease the heart rate. All right, you would decrease the heart rate, and thereby you would decrease the requirement of the cardiac muscles to oxygen and blood flow. Okay, and this is exactly the sodium channel that ivabradine is actually targeting. So it's an important link to know, and it's an important point to know about ivabradine and your sodium funny channels. Now I just want to tie everything together. From now on, if anybody, a person asks you, even USMLE asks you, some professor in your residency program asks you to explain exactly why a heart could contract, or how it should contract, or what causes everything to contract, you're going to be explaining it like this. As you already spoke about, so what I want an electrical impulse to be generated by your SA node, get transmitted to the AV node, and then through your bundle of His and Purkinje fibers. So whatever you're seeing in green is your nodal fibers that is triggering an electrical charge and carrying it around the heart. So if somebody asked you what would it look like scientifically speaking, you would tell them it would look something like this. You remember the curve? Phase 4, phase 0, phase 3, phase 4. The electrical impulse is generated. Now you need to transmit this electrical energy from your nodal fibers, alright, into your muscle fibers. So next in blue is your muscle cells. What does that curve look like? It looks like this. You guys know exactly how to explain these curves now because we've already been through it. Alright, so this is phase 0, phase 1, phase 2, phase 3 and phase 4. Now the bigger question. Your nodal fibers generated it, and your atrial and ventricular muscle fibers also conduct an electrical charge, and your curve looks like this. Question is, how do you convert electrical energy into mechanical energy? That's another important link that you must remember. Alright, so here we got the muscle cell. I drew it in brown, not because I'm brown, but because the muscle is brown. Alright, here we go. So muscle cells are right here. So when you want this impulse to travel into the muscle, and this needs to bring about contraction. So let's dissect this muscle. If I cut this muscle and open it out, you will see something known as myofibrils. Okay, these are the subunits that actually make up muscle cell. But eventually the myofibril is going to look something like this. This is the myofibril, and you know that it is surrounded by a protein or a layer known as sarcolemma. Alright, so the sarcolemma membrane protein, if I rip this off and open and see, what you're going to see is something known as T-tubules. Alright, you're going to see something known as T-tubules through which electrical current is going to travel. Electrical current is going to travel via these T-tubules, and right here you're going to have certain receptors that's going to be linked up to your sarcoplasmic reticulum. Alright, it's going to be linked up to a certain calcium channel here, and this is, once the impulse travels via T-tubules, this is going to be linked up to your sarcoplasmic reticulum and a channel. Alright, so what's going to happen is, once impulse travels here, it's going to jerk open your sarcoplasmic reticulum, and guess what it is going to spill? It's going to spill out a lot of calcium. So now suddenly you have a lot of calcium being spilled out into your cell, into your muscle cell. So how is this going to bring about contraction? Well, you're going to dissect it even further. So what is basically your contraction units of your muscle? You have something known as actin, right? You have actin filaments like this, right? And they have certain binding sites, which is for myosin, right? Actin binding sites, and you have myosin right here. But normally what happens is this actin binding, the myosin binding sites on actin is normally covered by something known as tropomyosin. All right, tropomyosin. Now what controls everything is something we always test on patients who are having a heart attack. What is that called? Troponin. Very good. So if you look at, there is something known as troponin that's attached to all of this unit, and you have three components of troponin, which is T, I and C. All right, so what happens is this calcium that you release is gonna come and bind to troponin C, and the moment it binds to troponin C, what happens is it just simply it's gonna release and it's gonna open up and remove this tropomyosin. Once the tropomyosin is removed from this site, what's going to happen is you're going to be exposing the binding sites of actin to the myosin. So the myosin is going to bind to the actin, and there you go. You got attachment, and now you have contraction. All right. This is exactly how the muscle is going to contract. So just to recuperate again, what's going to happen is your nodal fibers are going to trigger the stimulation. Your curve looks like this. Then it's going to travel by the muscle fibers. Your curve looks like this. That electrical impulse is going to travel in the muscle through the sarcolemmal membrane protein. Impulse is going to travel down the T tubules, and you have ryanodine calcium channel receptors here, which is going to pull out a small plunger, which is going to spill out a lot of calcium from your sarcoplasmic reticulum. What does the calcium do? It goes and binds to your troponin C, and once it binds to troponin C, the configuration changes. Your tropomyosin is pulled out, and now you're exposing the binding sites on actin to myosin. Contracts. Once it binds, you have muscle contraction. There you go. Now you know exactly how the heart contracts. So from now on, any question that you get with pertaining to these subjects, you should be able to answer and score really high on your exams. Alright guys, I hope you enjoyed watching this episode, and I would like for you guys to ask whatever questions you have and leave any comments below. Thank you.